Okay, so what I'm going to try and nip through really today in this part of the talk is talking about ultrasound in multiple pregnancy in the first trimester, talking a little bit about transabdominal versus transvaginal scanning, about viability scanning and dating, screening for chromosomal and structural defects in the first trimester, and a bit about non-invasive prenatal testing towards the end. So, if we look at obstetrics 30 years ago, when Mark was just a senior registrar, then most twins were diagnosed then by looking at the girth of the abdomen, whether people had polyhydramnios or not, palpation showing in excess of fetal parts. The textbooks talk about babies with small heads in relation to the size of the total abdomen. And if in doubt, they said you could try and get an ultrasound or an X-ray. So using that, 20% of twins at that stage used to be diagnosed in labour. And so we have come a long way. Now we're talking about chorionicity. And ultrasound in general, we use it early on for viability, the number of fetuses, placental localization, gestational age. And now in multiple pregnancies, we also talk about chorionicity, amnionicity, and then to look at certain abnormalities that are specific for multiple pregnancies as well. So one of the things that's always amazed me is, depending on where you are, what culture you're from, whether people feel that women tolerate transvaginal scanning or transabdominal scanning better, and which is better. Well, what we do know is that transvaginal scanning gives you better images in early gestation rather than transabdominal scanning. It gives you better images if the uterus is retroverted, so it's further away from the probe. In women with a high BMI, again, the uterus is further away from the probe. And then one of the key things is that for transabdominal scanning in the first trimester, most people request for bladder filling, and in transvaginal scanning, you need an empty bladder. So there's very little work about patient acceptability in the UK in the first trimester of pregnancy. And I think this is the biggest paper looking at that. And they looked at 160 women, and of those 160 women, these were women who were pregnant. They weren't necessarily multiple pregnancies, they were just people who had turned up for their first scan, no specific risk factors, and they were asked if they would undergo transvaginal scanning as well as transabdominal. Well, 19 women declined, 8 because of a fear of miscarriage, 7 a fear of discomfort, and 2 just said that they didn't want to do any research studies. 1 person didn't speak English, and 1 person said they didn't have time to have both. And what you find is quite interesting, actually. So on transabdominal scanning, the majority of patients, more than 90% of patients, if you don't fill the bladder, had no discomfort. That's not true, however, if you do bladder filling. So here, 5% of people say they have marked discomfort. And if you have bladder filling, in compared to no bladder filling. And you know, we all are quite happy for people to have bladder filling. If you look at transvaginal scanning in these same women, and when they were asked, well, 1 woman said that she had marked discomfort with transvaginal scanning. So acceptability-wise, pregnant women do feel that this is an acceptable procedure. And when we talk about discomfort, then we shouldn't forget that from the limited research we have, it appears that actually abdominal scanning with a full bladder is at least, but probably more, uncomfortable than transvaginal scanning. The same group looked at the need for transvaginal scanning for structural differences and looked at unselected population, 1,200 people, and basically they performed transabdominal and transvaginal scans on all of these women. Transabdominal scans, and if they couldn't see all of the features, they performed transvaginal scans. And you can see that from 10 weeks to 14 weeks, the need to perform an additional transvaginal scan changed from 100% to 10%. And they suggested that the key time is somewhere here, at 12 to 13 weeks. So if you do a detailed scan in the first trimester, around about 12 or 13 weeks, then it seems that you're much less likely to need to do a transvaginal scan as well. Viability, well, as the weeks go by, these need to be done by transvaginal scan initially, and you can see that the heart rate starts off quite slow and then increases as the baby gets bigger, reaching a maximum around about 9 weeks. And dating. Dating is something that often causes a problem with multiple pregnancies. And one of the things that people have to realise is that because fetuses are often of different size, if you are going to date, then you should be dating from the larger fetus. There has been work done looking at first trimester crown rump lengths and head circumferences in multiple pregnancies compared to singletons, and they are similar if you use people who have had ART techniques. Dating from the larger fetus rather than the smaller fetus is important because it does exclude the problem of dating from an abnormal fetus. So we already know that dichorionic pregnancies are more common than monochorionic. Defects in dichorionic pregnancies are equivalent to singletons, and they're commoner in monochorionic pregnancies. But some of the things that are really important are that most of these are discordant for structural differences. So 80% of monozygotic pregnancies, if they have an abnormality, are discordant for that abnormality. And that sort of goes along in a way with the epigenetics and things that, identical twins aren't identical all the way through. The vast majority of dichorionic twins are discordant for chromosomal differences, but not all of them. Because if they are dizygotic, even, then there's a chance that you could have two SIBs that are born at different times, both with the same chromosomal abnormality. It's important to bear in mind that invasive testing, especially CVS, carries a higher miscarriage risk in multiple pregnancies than it does in singletons. And invasive testing does bring in a whole series of problems that people have to start thinking about. Things about selective reduction and the inherent risks that gives both to the psychology of people, where some people feel that they can't choose between their babies, and the risk that they're putting a potentially normal fetus through. So there are lots of different diagnoses that you can make in the first trimester, and overall, if you looked at this analysis, that about 36% from this meta-analysis of abnormalities were detected. More recently, in this paper in 2004, you could see that actually the detection rate at different crown rump lengths for different abnormalities is vastly different. So, not unusually, abnormalities of the heart are poorly detected, as they are in the mid-trimester. Abnormalities of the kidneys are not as well detected, but things like the bladder, the abdomen, and the head and brain have excellent detection rates in the first trimester. screening is something that in singletons, you've seen this slide 1,000 times or similar slides to it, I'm sure, whereby the screening test we tend to offer this day is a combination of nuchal translucency and biochemical markers. And that will roughly give you a detection rate of about 90%. In twins, if you do the same screening tests, you get slightly different results. So if you keep the same false positive rate of 5%, then, or your same detection rate, you will end up with different results from singletons. So with nuchal translucency alone, in singletons with a false positive rate of 5%, your detection rate will be about 80%. And to get the same detection rate of trisomy 21 in dichorionic twins, you have a 10% false positive rate or a 13% false positive rate in monochorionic twins. And bearing in mind, these are the twins that have the most risk if you perform invasive procedures. This false positive rate seems to be quite high. The other thing that's really important is, although this improves with PAPA and HCG, your false positive rates are still the same. If you're working out the risks for these fetuses, you should always remember that for dichorionic pregnancies, you work out a risk for each individual fetus. And for monochorionic pregnancies, you work out an average risk. So they get one risk. And that risk is the average of their two NTs. So really, we need a better screening test for twins. So the other screening test that everybody's talking about these days is non-invasive prenatal testing. So non-invasive prenatal testing now is relatively well established in singletons for different problems, and it gives a very good result for the detection of trisomy 21. It is still a screening test though, and if the result comes back as positive, then you still have to perform an invasive test to confirm that diagnosis. It's done looking at free fetal DNA in maternal blood. It's available for about 10 weeks, but it's only available in the private sector at the moment. People are looking about whether it should be brought into the NHS via some sort of contingent testing. The detection rate with this test is greater than 99% for trisomy 21 with a very low false positive rate. What you do find is in about 5% of tests, you get no result whatsoever. And that's because you need your fetal fraction of the cell-free DNA needs to be more than 4% to get an accurate result. If you repeat the test, then about half of these will get a result. But the lower the fetal fraction, the less accurate your result is. And so when you see these test results, you should always interpret them in conjunction with the fetal fraction. So, in twins, or in multiple pregnancies, this is only available, and again it's available in the private sector still, for twins, not for higher order multiple pregnancies. One of the difficulties is accuracy data is really limited, and so counselling these women is much more difficult than it is for singletons. We do know that in the data that we do have, in singletons, on average, you get about 10% of your cell-free fraction of DNA is fetal. In monochorionic twins, that appears to be about 14%, In dichorionic twins, 8%. One of the problems with that 8%, however, is that, because remember we had a 4% limit for whether we could get a result or not, you don't tend to get half and half from each twin. So the proportion you get from each twin could be different. Therefore, there's a higher potential risk of a false negative. So if you have dichorionic twins, one of which has trisomy 21 and one of which doesn't, and the one with trisomy 21 has a relatively low fetal fraction, you may get a result that would suggest that both twins have got a normal chromosomal abnormality, or that there's no abnormality detected. At the moment, really, there's only one significant paper with numbers in that looks at the efficacy of this. This paper had two parts to it. There was a prospective part and a stored samples part. Of this prospective part, the outcomes of all the pregnancies haven't been written up. And so there were a considerable number of these pregnancies that were still ongoing. The stored samples were samples that they knew the karyotype of previously, and of people that had combined first trimester screening, and then looked at those results. So of the stored samples, they got risk scores for 192 of the cases, with 15 cases there being no results. Of those 15 cases, one of those was a case of known trisomy 18, and two of them were cases of trisomy 13. There was, however, no false positives. And for non-invasive testing, for those who aren't aware, the detection rate for 18 and 13 is lower than it is for trisomy 21. There were 10 cases of trisomy 21 in that series, and of those, 8 gave a risk score of greater than 99%. So effectively, 8 were detected, with one other with a case of 72%. So these really were fairly comfortably detected. The other case was a case of dichorionic twins, with one twin being euploid and the other twin of trisomy 21 risk was 1 in 714. And this one arguably wasn't detected. All of the other results that came back were 1 in 10,000. In the prospective study, they had 68 patients. Of those, so these were patients with had a relatively high abnormality risk, you could see, of the 68, because there are 3 babies with trisomies out of the 68, and that's all because of maternal age. So these people attended, this is Kipros's group in London, and they attended for combined first trimester screening for that, and then underwent this as well. So you had no result in 13% of cases. Of those, much as in the singletons, this hasn't changed, then 4 of these you had a result. Of these, you got 59 results. Of the 59 results, no trisomy was detected in 56 cases, and there was 2 trisomy 21s and 1 18, both of which were confirmed. More recently, there's been a poster presentation that's been produced by the company that does one of the non-invasive tests on twin pregnancies, and they've got a total of 1,440 twin pregnancies in their series to date. Of those pregnancies, There are an awful lot of unconfirmed outcomes because these are coming from samples all over the world. However, there are no false positive results that they're aware of at the moment. This data is also being written up now and will be added to constantly. And so it's possible that this might be a test that is useful in women with twins and is likely. And theoretically, there are no reasons why it should be less useful in monochorionic twins than in singletons. However, there is an issue if the twins are dichorionic. So, if we're thinking about non-invasive testing in multiple pregnancy, things to remember are, at the moment, it's only available for twins. So if you request it for higher order multiple pregnancies, they won't do it at all. Accuracy data is limited, so if you counsel somebody about this, you have to say that the detection rates and the false positive rates are unknown. Dichorionic pregnancies don't have equal amounts of cell-free DNA. You've got to interpret all results, not just in singletons, not just in multiples, but in singletons as well, bearing in mind the fetal fraction. And the average fetal fraction of cell-free DNA changes between singletons, monochorionic twins, and dichorionic twins. So in summary, what we do know, higher perinatal mortality rate with monochorionic twins. We know that transvaginal ultrasound is well tolerated by women. We know that it's needed less to diagnose structural defects after 12 weeks of pregnancy. You should remember that you've got to date by the larger fetus. Composite scanning is necessary for determination of chorionicity, as we discussed in the first lecture. Twins with abnormalities are usually discordant, regardless of chorionicity. First trimester screening is available for twins. Use the mean nuchal translucency for monochorionic twins and an individual risk for dichorionic twins. Using this test, you have a higher false negative than singletons. Non-invasive prenatal testing is available, but there's less data than in singleton pregnancies, and you've got to interpret your result in the whole context of what the fetal fraction is. Thank you. I have finished this time.